Hi, my name is Tristan Smolarczyk, and this is my patient evaluation 1. It's over the lower extremity. My first evaluation I did this semester at my clinical site at South Vermillion, I evaluated an ankle, and it was a very terrible evaluation. And so afterwards I discussed it with my preceptor, Alex Van Dusen, and we had a good conversation about everything I did wrong and everything I did right and what I should work on overall. And I discussed that I seemed very insecure and very not confident at all about what I was talking to my patient about. I was stuttering, I stopped every 5 seconds, I had blanked on questions to ask. So overall, he said I need to improve my confidence. I also didn't test anything bilaterally except for range of motion. So Alex said I need to work on doing everything bilaterally, practicing doing that, as well as just asking more questions, because a majority of the information we get is from our history. And I didn't take a very good history, so he and I discussed every question that I asked and what I could have asked on top of those to get a more detailed history. And then overall, he said my evaluation process was very slow, which in a real world setting I need to be a lot quicker, because you can't sit there and spend 20 minutes on an evaluation. It's not very probable, and you're typically going to have more patients waiting, and you're going to have to get them all in one at a time very quickly. So he overall discussed with me that I need to speed up my evaluations, as well as when I'm doing everything bilaterally, I need to make sure I use the goniometer, because especially if I can tell there are limitations, he said. If there are limitations, then it's usually a good idea to use the goniometer, just so you can check to see if how much of a limitation there is and what you need to work on to get back to what the other leg or something like that is doing. For instance, my patient lacked some movement, so, and I think it was eversion or something like that. They lacked an eversion and had pain when they inverted their ankle. And so Alex said I need to take a goniometer and measure that, just so I can make sure what is lacking and how much and what I need to get the patient back to. And then he told me one thing I missed when I was doing my evaluation was I completely forgot to test for a fracture whatsoever. And so that's one thing I should always do, just to rule it out. But after he and I discussed it, I went back through and thought about my evaluation process. It wasn't that terrible of an evaluation process. My clinical decision making wasn't off. I was right in my diagnosis. I just happened to be lacking overall, I think. But my clinical decision making is pretty steady. I did my history questions. I determined that the pain was more superficial rather than deep, so that's part of the reason I kind of skipped over doing fracture testing, because she said the pain was superficial. It wasn't deep like a bone. It wasn't even over the bone necessarily. So I was thinking more along the lines of away from any kind of fracture. And then I just continue on with my basic questions like location of pain, pain level, how long has pain been going on, type of pain, and all that fun stuff. And then I continued on to do range of motion, which range of motion is where I got a majority of my content, because I realized where she was lacking, and I realized what needed to be worked on, because she had some issues going through some of her, if I'm not mistaken, she had some limitations with her eversion, plantar flexion, and dorsiflexion, and then she felt like a stretch with inversion. And so it's kind of like where I knew, because she wasn't in a lot of pain, but she had some pain with the inversion because it felt like it was stretching it. And then with eversion, plantar flexion, dorsiflexion, she just had some limitations, almost like they were weak. And so I started getting on to maybe more musculature. because if she was in pain or if it was a ligament fracture, it would probably be more sharp and she wouldn't have wanted to even do the motions at all. And then I went on to manual muscle tests. This definitely gave me a lot of information because I tested everything from her fibularis muscles to her posterior tibialis and anterior tibialis. Those are the 4 main tests I did, and that's where I kind of caught on to. Her anterior tibialis and her posterior tibialis were fine. There was no deficits whatsoever. But then when it came to both her fibularis brevis and longus, there were some deficits. Fibularis brevis more so than the longus. And this kind of let me know that the pain that she was having that was going up through her, like, side of her calf almost, into her ankle, could have been more muscular related. Because she said she had rolled her ankle prior to that moment. It was like a couple weeks ago. And she was just like, the pain in her ankle, which wasn't really up in her, it was more towards her calf than it was in her ankle. But it made its way down into her ankle towards where the attachment sites of those muscles are. And so it kind of gave me the idea that it probably was more musculature. She probably strained something. And then, just to top it all off, I went through all of the special tests. And I went through the Taylor tilts, inversion and eversion, as well as the anterior drawer. I did Tenel-Stein too, just to make sure there's no other problems going on in the ankle. I don't really know. It was one of my worst evaluations I think I did. I didn't test for fracture, but everything I had, there was negative. There was no laxity whatsoever. She may have had some pain with the eversion Taylor tilt, just because it tilted that way. But anyway, sorry. She had no deficits in any of her special tests. There's no laxity, nothing like that. Most of the tests were negative. And so overall, I made the clinical decision that all the things I was testing for ligament-wise probably wasn't a ligament whatsoever. Again, I still think I should have tested for a fracture because, I mean, you never know what you could have gotten with it, even though it turned out to be exactly what I thought it was. Or I still should have tested for a fracture just to rule it out. But overall, with going through each of those steps, I feel I made a good decision in deciding it was a fibularis strain because she showed all the signs. It was textbook strain of like a muscle. I overall was just trying to make sure it wasn't anything serious. Like, when she said it was superficial, not deep, I ruled out fracture. I made sure that there was no, like, ligamentous, there was no swelling, nothing like that. And so I made the clinical decision, and she wasn't even painful around any of the ligaments. I made the clinical decision that she didn't have any sprains. But just because of, like, where she was tender and where she was weak and where she was having the pain, I overall decided that the fibularis muscle group was definitely involved, and I turned out to be quite right. I mean, Alex and I had the conversation afterwards because he would have made the same decision. He just would have went more in depth with the evaluation, so he could have had more on file for that, just so he knew. And if she needed to go to the doctor for any reason, he could have had that information. But I guess my, like, future plan for improvement would have to involve just being more open-minded and overall just asking more history questions, because you get a lot of information out of that. And I know I need to be quicker with my evaluation process, because if I do plan on working in an athletic training environment, there's no place in which I can sit there and do like a 20-minute, 30-minute evaluation even. So, like, high school-wise, I need to be able to get them in, get them out, work with them on what they need to be working on as quick as possible, and taking on the next patient, because quickness is kind of part of the job. I know I need to always test for a fracture because it's a good thing to rule out. Because if you don't rule out a fracture at all and they turn out to have one, you can be quite liable and basically be in trouble for that. So next time I know I'm going to rule out the fracture first, just in case, just because of the location and where she was having the pain. And then I know I need to practice using the goniometer more. It's definitely something I've been working on more and more lately, trying to get out the goniometer when I do evaluations and just testing any range I need to, just to practice mostly. And then I also am working on memorizing the ranges of which each motion is to be normal. So overall, Alex and I discussed my confidence issues. We discussed what I need to do better, how I can improve, and what I did well. My clinical decision making is not great. I obviously have a lot to work on, but I am capable of breaking everything down and ruling out the worst possible things. But then I know what I need to work on for the future, and some of this I have already been working on and improving on, so I'm quite proud of myself, and it's definitely stuff I'm not going to forget because I know I messed up so badly the first time. So action plan is just to be more confident, go in there, own the evaluation, ask all the right questions, ask in-depth questions, be quick, be concise, palpate, and measure everything with reason, and just make sure I'm doing my job well overall.